Since my work is based around the learning outcomes model, I often get questions around, I've done this simulation of this course. What is it? How can I measure my outcome? And when we get into this discussion, my next question is, well, what problem were you solving? And problem identification is the core, to me, of figuring out a measurable outcome, which is a core principle of learning. To review, we need to go back to the basics of curriculum development. And I strongly suggest that you pick up Kern's book, The Six-Step Model, as a basic approach. This starts with problem identification, general needs assessment, then goes to targeted needs assessment, then goals and objectives, then educational strategies, then implementation, then feedback and outcomes. What happens in simulation is we often jump to educational strategies. I want to do a sim, or I want to do a code. The problem is when you jump to that, you may address a problem that doesn't exist, or you may just be playing with the toys, which was okay in simulation a while ago, but now we've got to show value for everything we do. And if we're going to make that movement from education to learning that has outcomes, we need to shift and focus on the problem. I'll give you an example of this. I get a phone call, which I'm sure most simulation centers have gotten, of I want to do codes. And that's common. Well, the problem there is that often people see the mannequins and they think of Resusci Annie, or let's just do CPR. So I started asking deeper. I said, well, why do you want to do codes? And the answer was, well, we're on an oncology unit and we have a lot of codes. I said, well, that's fair, but your team is not the code team. They said, yeah, well, that's true. I said, but we have a lot of new nurses. Okay. Well, then why do a lot of new nurses have to learn about codes if the code team is going to be there in a few minutes? And then we started diving in deeper, looking through some of the data, and we found that over 50% of the staff were new, or less than 1 year, and the difficulty was actually not in what to do with the code, but when to call one, and what to do once you've called one. Because what happened was sometimes you call a code and the nurse would disappear, be in the bathroom, or just stand there and not know what to do. So the actual problem was critical thinking, knowing when to call a code, or a rapid response team, and then what to do in the first 5 minutes. In that case, we brought in a patient, one that was going to be fine, just needed a little albuterol, and one that was going to code, and had them do a comparison process, actually called analogical reasoning, to figure out which one is which. And when we started off, of course, the one that needed the code didn't get it called, and the one who was going to be fine would get a code called. But after a while, people start working through it. And they start realizing that there are things they can do to prevent a code. If they can call rapid response earlier, it can prevent a code. And then also if a code does happen, what do you do the first 5 minutes? You do CPR, you backboard, defibrillate if need be, code card. What we found was that actually the rapid response team calls went up, the code calls went down. That's a measurable outcome that actually then can be translated into dollar savings. Now if we had just jumped in and said, well, let's do a code, great, that might be a great scenario, but we may not get the same measure. At the same time, we looked at the codes and what we did with the code team and said, all right, well, do we have good measures for that? What we found was the time to defibrillation was very short to start. There really wasn't much area to make improvement. And at the same time, the in-hospital survival rate was pretty high. Wasn't much time to do that. So the scenarios, because it was good for practice, but there's not a measurable outcome there. And it's truly not a problem we're trying to solve except keeping practice. So when you look at problem identification, you need to dive in deep. You can break out your lean tool, Six Sigma. It works great. 5 whys. Don't stop at the first why. Dive deep into what's going on. And really what you're looking to see is what are the impacts of the learner, their experience, and the environment, going back to the learning outcomes model, on that process. What is the problem you're truly trying to solve? I'll give you another great example of it. Common problem, hand washing. Well, in hand washing, I've been all around looking at different places, some places as much as 8 hours of training on hand washing. Well, hand washing is not a knowledge problem. It's not an education problem of, I don't know I should wash my hands, because our moms teach us to do that. Well, instead, we looked at the learner experience environment. We found that the first thing in the environment was that the sinks, some were busted, or that the alcohol dispensers, some of the materials that we're using was actually causing a contact dermatitis for some of the caregivers, up to 10% of them. So we had to use a different alcohol-based product. In the experience, what we found was that people would actually go in and say, hey, you forgot to wash your hands, and then get their head bitten off. On the individuals, when we start talking about their mental models, I want to use that example. It's great. It shows the impact that we have on learners. I watched somebody that was a EVS worker, a janitor, going into a room. He has gloves on, goes into the room, washes his hands with his gloves on, walks out, washes his hands on the way out with his gloves on, goes in the next room with his gloves on, washes in and out. And I watched him wash in, wash out, but he never took his gloves off. And I had to understand this. Well, what we found as we started diving into problem identification was that we had told him, and this is what he told us, we had told him that we need to conserve supplies because of finance. And what he had decided was, well, I would use a whole box of gloves throughout the day so I can conserve gloves because that's just there to protect me from the patient and I can wash my gloves. We had to explain to him, it's fine. Take the gloves off, wash your hands. It'll be fine. It's not about adding more knowledge. It's about changing people's mental models in an environment that's supportive and giving them experiences to help. We need to dive in. Well, in problem identification, what we had to do was we had to actually look at our audit logs. We had to go talk to people, do focus groups, which is the topic for the next video. And we had to actually talk to people and say, what works, what doesn't? Result, real simple. Borrowed something from the influencer, real simple mental model. Wash in, wash out, 200% accountability, say thank you, which means everybody wash it in, wash it out. I have your back, you have mine. And if I say he didn't wash it, you say thank you and go wash your hands. No battles. That being said, you got to create an environment then that supports that, and the first person that goes against that, you're going to have to address. The educational intervention is very small. It's not about the simulation experience. Problem identification is going to help you understand the core root of it. The other part of problem identification is going to help bring together groups like quality improvement, process improvement, Six Sigma Lean groups in learning to come to a solution. To do a problem identification, the biggest thing you want to do is go talk to the customer. Go to Gemba in the world. But you want to actually hear from people what it is that's going on. And try to take a 360 approach. Talk to the actual learners, their managers, their educators, and see what's going on. And then there's nothing better than just observing. Spend a day in their shoes to figure out what's going on. That may sound like a lot of time, and it is. When I'm doing curriculum development, I spend about 70% of my time in problem identification and needs assessment. Because once I have that, everything else is easy. My outcomes will come right out of that. My process will come right out of that. But you want to figure that out. In simulation centers, someone may come to you and say, well, my problem is my dean says I have to put a simulation in every one of my classes. That's actually not a problem. That's an opportunity. And when you're talking about that, adding simulation to every course may or may not help. The next question becomes, what difficulty are the students having? How can we help them improve? Where would this help? And how does it fit? Rather than just, let me do a scenario. That's why some sim centers, myself included, have gone to not giving out their list of cases. You don't want people just picking a random case because then they're just coming to do a random thing and it may not have the outcome. Everything should be tied to a problem. The other thing you can do within a healthcare system is get the learning environment. The other thing you can do is within the healthcare system, get the learning department involved in root cause analysis. Have them involved because the learning opportunities are huge, and sometimes a learning eyes on it can see something different. You want to be involved early rather than being told, hey, we need to do a class on this, or even worse, hey, we need to do an online module about this. In the learning standpoint, we need to ask the question, are you doing this to check off a box to say you did it, or are you looking for an outcome? If you're looking for an outcome, then we need to do problem identification. We need to dive in, find the individual experience environment, and put those together into a process that then creates a curriculum that will improve. For those in sim centers, what that's going to allow you to do is start measuring the impact of what you do. That being said, it does put more at risk because you're actually putting your money where your mouth is, but outcomes are what pay the bill. If you're truly solving problems for people, then all of a sudden you're wanted. You know, my way to do it is finding some chief officer, figure out what their bonus is tied to, what is driving them crazy, and fix that problem. Doesn't matter if it's patient satisfaction, doesn't matter if it's quality, whatever it is, take a problem and fix it. Once you fix the first problem, everything else gets easier.